In this video, we're going to review dopamine and we're going to apply it to a case that's relevant to the pre-hospital setting. Because again, we need to go over a patient and their circumstances and weigh the risk and the benefits to giving fluid therapy, as well as dopamine. What are the mechanisms of action that dopamine can help in this patient and its context, and as well, what are the risks, right? Because we always have to weigh the risk and the benefits to each medication that we perform. So that's an overview of this. So if we look at the case, you're called to code for a patient experiencing chest discomfort while responding to the call. You advise the patient is losing consciousness, and you arrive, and the patient's wife brings you into the kitchen where the patient collapsed. So right away, I'm sure the vast majority of us have done this call or a call similar. So the wife states Richard has been having chest pain all day. That felt like a pressure. He was short of breath. He also felt quite weak. He's had one MI before. And you find him he's quite lethargic. He has no radial pulses. So overall, this patient's pretty sick, right? So obviously he's got a pretty significant medical history. He's had symptomologies all day manifesting that suggests his cardiac ischemia from the pressure, the shortness of breath, the weakness, right? And now he has insufficient amount of perfusion evident from his no radial pulses. So his blood pressure is probably low, and that's probably the reason why, or part of the reason why he's quite lethargic. So if we look at his medications now, he's on bisoprolol, a beta blocker. He's on ramipril, which is an ACE inhibitor. He's on Crestor, right? So he's got pretty significant medical history or evident that he's most likely has cardiovascular diseases. So bisoprolol, that can be prescribed for arrhythmias as well as hypertension, other cardiovascular disorders. Ramipril, again, hypertension, congestive heart failure, etc. Crestor, that's to lower his cholesterol because we know higher rates or a higher total cholesterol level or higher LDL cholesterol levels has a significant impact on cardiovascular disease. And cardiovascular disease is still the leading cause of death and morbidity in the world. So we will experience these patients, right? These are pretty common. So if we continue on, that's his heart rate. So we see he's a sinus bradycardia, about 40 beats per minute. So is this a rate problem? What's blood pressure? What's causing the rate problem if it is indeed that? What else is going on? And as well, we know, we just discussed he's on a beta blocker, right? So is the beta blocker causing this low heart rate? Is it exacerbating his underlying condition? Or what's going on, right? So these are all the things we have to ascertain. Then if we do listen to his lungs, we hear coarse crackles throat. So this is most likely cardiogenic in nature, evident from his clinical manifestations, evident from his blood pressure, his significant past medical history, etc. Right? So, okay, this patient's really sick now, like low heart rate, probably low blood pressure. He's got acute cardiogenic pulmonary edema. What's causing all this? So if we look at his blood pressure, yeah, so it's pretty evident that his blood pressure is low. Now we can determine that for fact it's 80 on 40. So this patient probably has a medical history of hypertension, right? So what if his normal is 150 on 90? And now 80 on 40 is technically hypotensive, but that's pretty low in comparison to what he normally responds to every day, right? His metabolic needs are totally operational 150 on 90, even though it increases his risk of cardiovascular disease. But now today's 80 on 40, that's probably extra low for him. And this is why he's manifesting so hyperperfused, right? So this is problematic. As well, he's got acute cardiogenic pulmonary edema evident from the coarse crackles and the other clinical manifestations. So his SATs are low, 84%. So obviously with the low blood pressure and the low oxygen, this is impairing his ability to supply sufficient amount of oxygen to his tissues, his vital organs, etc. Right? This is why he's altered and lethargic with a low GCS of 6. This is bad. As well, he's obviously compensating for all these insults, and so he's going to start to breathe quicker to hopefully get more oxygen, but he blows off more CO2, and this drops his CO2 levels, and his respiratory rate is 28, so he's pretty short of breath. His temperature is 36.1, so overall, Richard's pretty sick. So we look at his 12 lead on the monitor. We can see even just from not even the printout, he has ST elevation. So if we actually go to the printout, we can see here he's got ST elevation in lead 1, AVL. He's got ST depression in lead 3, as well AVF. He's got ST elevation again in V2, V3, V4, V5, V6. So overall, this patient is manifesting with cardiogenic shock and caused by a myocardial infarction, because the main reasons for cardiogenic shock are an ST elevation and MI. Non-STEMIs can cause them less than 5% of the time, around 5% of the time. There's other causes as well, but overall, this patient's experiencing an ST elevation and MI leading to cardiogenic shock. And they have a high mortality. Cardiogenic shock has one of the highest mortalities of all the shock states, around 43% in comparison to the other one. And this means that 40 to 50% of their left ventricle at minimum is damaged, and it's compromising the heart's ability to function as a pump. So if it can't squeeze out the blood that it receives, it backs up and you have lack of perfusion because of it. So this is problematic. So also, this patient has extensive ST elevation throughout. So this is most likely a widowmaker MI, which is a high occlusion in the left coronary artery, which obstructs all this blood flow to a significant portion of our myocardium. So this is why this patient is so severely sick. And this is also why they have acute cardiogenic pulmonary edema, because 66 or approximately 66% of all patients in cardiogenic shock will manifest with pulmonary edema, because if 40 to 50% of your main ventricle is compromised, it can no longer function as a pump. Blood essentially is going to back up in the left atrium into the pulmonary circulation, into the interstitial spaces around our alveoli and into the alveoli themselves. That's going to disrupt gas exchange. So all this is cyclical. And how we compensate is via the sympathetic nervous system. We cause vasoconstriction, increase our heart rate, retain more fluid, and this all exacerbates the workload of the heart. So we utilize more oxygen. So our MVO2 goes up, and this exacerbates the damage. It's cyclical. So you can see how these patients have such a severe risk of mortality and significant morbidity. So we are kind of discuss some of these questions as well, like how do we treat this patient now? And we have to be careful and very judicious in our treatment options. So this patient's obviously experiencing an ST elevation MI. This patient had atherosclerosis, which is a main risk factor for cardiovascular disease, obviously, because when you have atherosclerosis, obviously that's damage to your endothelial lining. So the inside lining of your blood vessels. And that is only one cell thick. And there's many different risk factors for cardiovascular disease. Obviously, genetics can play a role. Age, the older we get, the higher likelihood of cardiovascular disease goes up. What if you smoke? What if you're diabetic? There's different risk factors for gender as well. What if you have kidney disease, sleep apnea? Do you smoke? Have angina, etc., right? Are you physically inactive? You have a poor diet, nutrition, etc., right? All these can accumulate and lead to an increased risk of cardiovascular disease. And this causes damage to your endothelial lining. Then eventually what happens is that damage becomes so problematic, this leads to cholesterol being trapped in there. So the LDL cholesterols or the VLDL cholesterol, so low lipid density lipoprotein and very low density lipoprotein. So this can get trapped in the endothelial lining or subendothelial lining. Their immune system attacks it because this is foreign. We need to rectify this. Let's go. But this creates all these foam cells and smooth muscles accumulate, and this actually leads to plaque buildup. So this is why all this plaque and damage can occur. And then this manifests as vulnerable plaque, because you can have different types of plaque, etc., right? So when vulnerable plaque is present, this can lead to it rupturing. When the plaque actually ruptures, it hits our blood supply, and then tissue factors activated, and that leads to the clot formation because the body's trying to heal itself. But then again, if you create this thrombus, that leads to obstruction of blood flow distal to the area. And the amount of blood flow that's obstructed, it'll depend on the size of the thrombus, collateral circulation, what's your comorbidities, how hard is the heart working, how much preload, how much afterload, etc., right? This is all a factor. And as you can see over time, if this patient's coronary artery is narrowed, that's going to obstruct blood flow. So this is why patients can manifest with stable angina, because initially you start manifesting symptoms when you exert yourself, because the metabolic need is higher than the supply. So that's why when you exert yourself, they go for walks or they work out in the garden and have you. They manifest with chest pain, shortness of breath, weakness, and dizziness, but usually the symptoms go away when they take their nitro for the vasodilation effects. As well as they rest, all the symptoms subside. Eventually they can progress into unstable angina, where they get these clinical manifestations at rest because the need is higher than the supply, but it doesn't lead to a full ST elevation MI or a non-STEMI. And eventually plaque can rupture, and that can lead to the thrombus formation, etc. So this is the inside of a pretty atherosclerotic artery. Pretty problematic. I would not want these arteries. And as you can see, blood should flow pretty with no issues at all, right? But if you actually start to narrow in from all those plaque buildup or this plaque creation and atherosclerosis, this is going to obstruct blood flow, and then it's going to compromise your circulation perfusion statuses. So this patient, we said, was probably manifesting with a widowmaker MI. So this is a high occlusion because you have a right coronary artery over here that supplies the SA node, the AV node, and can wrap down to supply the inferior left ventricle. But the left coronary artery kind of branches off into the circumflex, which wraps around here, and the left anterior descending artery. So imagine you had occlusion up here. This would obstruct and infarct all this distal area, and obviously the AV nodes here, the septum, the anterior left ventricle, right, lateral walls, etc. This is a pretty extensive myocardial infarction. And again, that's why they have high morbidity and mortality and are prone to cardiogenic shock. So we look, you have the different coronary arteries here. I didn't create this. I'm definitely not that creative to ever think of something like this. And if you apply the actual coronary arteries for the different limb leads for the visual people, you can see the left circumflex can supply the higher lateral walls and as well as the lower lateral walls of the 12 lead. Left anterior descending supplies V1, V4, part of V5, V2, V3, etc. And the right coronary artery can supply obviously the inferior leads, lead 2, lead 3, and AVF, etc. Right? So that's a pretty interesting way to kind of look at it. And ways atherosclerosis can accumulate and actually occlusion can happen. So this is your normal kind of vessel, right? There's no obstruction, blood can flow freely through it. However, once you start kind of having this atherosclerosis, you can see this is narrowing the actual lumen size of your vessel, which can compromise blood flow. And eventually it can accumulate even more, or plaque starts to accumulate extensively, and then eventually plaque ruptures and it actually leads to full-on occlusion from the thrombus formation. So this is obviously 100% occluded, right? You have a thrombus, you have atherosclerosis, the plaque ruptured, it led to this tissue factor being activated and led to the formation of a thrombus. So it's a marble in a hose. If you put a large enough marble in a hose and turn on the hose, water's not going to throw fluid freely, if at all, depending on the size of the hose and the actual occlusion. That's the same thing for our coronary arteries, right? And our coronary arteries have this amazing capability. They actually supply our own blood supply to the heart. And if that is compromised significantly, this leads to irreversible cell death within 3 to 5 minutes. And this is why time is tissue. You have to get them to the cath lab as soon as possible if they need it. Then obviously, this patient was experiencing ST elevation MI. So as a friendly reminder, like this means that all 3 layers of the heart are affected. So initially it starts when you have the damage kind of initiating. This starts in your endocardium, so the inner layers, and it works its way up to the outer layers, right? But when you have a transmural MI or ST elevation, myocardial infarction, that means all 3 layers are affected. So that's why it's pretty extensive, and this leads to such problematic damage. Because this is the actual coronary artery, then arteries grow within and have all these vessels that supply the endocardium, because you can see the inner layers would be affected first, and eventually the blood supply is going to become so obstructed, it's going to obstruct all 3 layers where it causes irreversible damage. So you can see here, if we just look at a normal ECG, it's going to manifest as a P wave, QRS, and T wave as normal. There is no injury, blood can flow through it. That's totally fine. There is no affected or detrimental muscle. But then if you look at a subendocardial injury, so that means the endocardium or the inner lining is affected and it hasn't led to or progressed to a full transmural MI. This can manifest with ST depression, flip T waves, etc. So those are the kind of beginning stages, and these are why these patients can suffer this damage. But again, it's not a true ST elevation MI at this point in time. But if it progresses or the occlusion gets severe and significant enough, this leads to a full transmural MI that can manifest with ST elevation because all 3 layers are affected, and this is obstructing electrical impulses, and this is why it manifests with ST elevation. Now, we already kind of alluded to like myocardial oxygen supply and demand. So they have to be equal, but imagine your demand is a lot higher than the actual supply. So this can be problematic, and that's all dictated on the patient's heart rate, contractility, ventricular wall compression, how much time it takes to actually fill the actual ventricles during diastole, preload, afterload, etc., right? So these are all factors, and if these are all affected, this increases the amount of workload in our heart, and this may be even higher than the supply we can give it, which can be problematic. And again, if we look at the area, so if we have an occlusion down here and we've infarcted that area, that is still pretty significant. But again, what if we actually had an infarct up here and that led to all this portion of the myocardial damaged and destroyed? That can be even more significant, right? So that's why it's all in context what coronary artery is affected, what's the size of the vessel, what collateral circulation is in place, etc. So this is all multifactorial. And if we look at the risk factors for cardiogenic shock in nature, the older age, if you had an anterior MI, have you had diabetes mellitus, or are you diagnosed with diabetes? Do you have multivessel coronary artery disease? Have you had a significant MI, or have you had a previous MI? Do you have an ST elevation MI currently, or a left bundle branch block? So if we apply it to this case study, yeah, this patient is approximately 80 years old, so he's at higher risk for cardiovascular disease and complications as well. This patient does have an anterior MI or a widowmaker MI that affects significant portions of his anterior myocardium. He has a history of hypertension. He doesn't have a history of diabetes. He probably has a history of multivessel coronary disease from his other risk factors as well. He's had one MI before, and he's currently experiencing an ST elevation MI. So this patient hits numerous risk factors for cardiogenic shock, and these all exacerbate and increase his risk for morbidity and mortality. So if we actually look at the medical directives here for cardiogenic shock, you can see that you have to have a STEMI positive 12 lead and experiencing cardiogenic shock, which is evident that you have refractory hypertension, so a blood pressure of less than 90 millimeters of mercury, but you're also experiencing hypoperfusion. So evident from cool pale diaphoresis, you have an altered mental status from lack of perfusion to your brain. What if you have pulmonary crackles, etc., right? You're mottled, you're cyanotic, etc., you're producing low urine output. These are all evident you could be suffering from cardiogenic shock. So to give a fluid bolus, you have to be at least 18 years or older, hypotensive, and chest auscultation is clear. Because you're only truly contraindicated for a fluid bolus if you have pulmonary edema that's cardiogenic in nature. So if someone aspirates, they technically can still receive a fluid bolus if they will benefit from it. If the patient has a clear chest and they have peripheral edema, they still could receive a fluid bolus. We have to be careful and judicious, but again, they're not contraindicated until they have pulmonary edema from acute cardiogenic pulmonary edema. That's how we actually know they're contraindicated. But again, cardiogenic shock is probably not a fluid problem. And this is why the actual medical directives are written 10 mils per kilo for a fluid bolus, and we give to a max of 1,000 mils in comparison to giving 20 mils per kilo to a max of 2 liters. Because one, you always think about a fluid bolus. Can the heart take it? Can the heart use it? So we give a fluid bolus to increase the patient's preload to hopefully help increase their perfusion status, etc. But if 40 to 50% of their left ventricle is destroyed and they can no longer function as a pump and essentially all their blood backs up, it's like, do I really want to increase their fluid that much? So it's all depending on the patient, how old are they, what are their comorbidities, what vessels accumulate, how big's the infarct, etc., how significant is the damage. So that's all dependent. Some patients are non-fluid responsive. Some patients are fluid responsive in cardiogenic shock. But that's why it's always first-line treatment. If they're indicated and there is no contraindication, they can just receive a fluid bolus. Then if they're still demonstrating signs of being hypoperfused, you can give them dopamine if there is a perceived benefit to it. And the only the indication for that is being hypotensive. So again, we can start an intravenous. It may be difficult to get an IV in this patient because they're so hyperperfused, probably periphery shut down, but it is an option. And again, if we look at the contraindications for dopamine, because we already discussed the fluid bolus, allergy or sensitivity to dopamine, that's pretty straightforward, right? Tachydysrhythmia is excluding sinus tach. So we know there is a risk to giving dopamine leading to proarrhythmic events, especially those dosages 10 micrograms per kilogram per minute. Those higher doses can lead to proarrhythmic events. So that's why if patients are experiencing rapid AFib, atrial flutters, SVTs, multifocal atrial tachycardia, etc., we don't want to add more fuel to the fire because dopamine does have benefits for what we give it for in the pre-hospital setting, but I'm not going to add a proarrhythmic drug if you're experiencing a tachyarrhythmia. So that's why that contraindication is in there. And mechanical shock states. If the patient's experiencing a tension pneumothorax, they have cardiac tamponade, they have a dissecting aneurysm, they have a pulmonary embolism, there won't be any benefit because they have an impairment of diastolic filling and as well as preload. Because if they're having a tension pneumothorax, their preload's diminished because the vessels are twisted off and blood can't return to it sufficiently. So dopamine will not rectify that situation, right? You have to cater your treatments to alleviate the obstruction or mechanical shock causes, then rectify anything else. Hypovolemia, again, this patient's probably not going to be hypovolemic, but if they are, the beneficial treatment for that is fluid therapy. Then if the hypovolemia is rectified and they're still manifesting with cardiogenic shock, dopamine can be considered. But we always want to weigh the risks and the benefits and treat the underlying cause with the appropriate treatments, and then address further subsequent complications. And pheochromocytoma is contraindicated because that's an adrenal gland tumor. Dopamine is a precursor to epinephrine and norepinephrine. It's found in the adrenal gland, so this can lead to hypertensive crises, tachyarrhythmias, etc., right? Because you have this huge surge of catecholamines, and this could lead to adverse events. So if we look at our actual dosages of dopamine, the key with dopamine is that it's a very beneficial drug because different dosages have different effects. So we can give it for those bradycardic patients, we can improve renal perfusion, we can give those higher dosages that can cause increased vasoconstriction, etc. So we can give it for different pathologies, whether it's for a raw setting, they're hypoperfused, we can give it for bradycardias that are hemodynamically unstable, etc., or cardiogenic shock. We can titrate to effect. But the key is we want to give the least amount of vasopressor to achieve a normal amount of blood pressure, because we don't want a blood pressure of 140, 120, or 130. We only want to titrate to get their blood pressure between 90 and 110. Because again, we want to achieve give the least amount of vasopressor to achieve a normal mean arterial pressure of 65 millimeters of mercury, which should equate to a systolic blood pressure between 90 and 110. Because if you have a mean arterial pressure 60 and 65, that means you're sufficiently perfusing your vital organs. And that's all we want to do, because we do know dopamine can cause an increase in proarrhythmic events. It has side effects, increase your myocardial oxygen consumption, because you're causing this heart to work harder. If you're increasing its heart rate, which we go back to that diagram, you can increase vasoconstriction, you can increase the amount of preload, etc., right? So it's like we have to have this balance. But again, what's the alternative? If we don't give this and you're hypoperfused, that leads to anaerobic metabolism, that leads to a 43% chance of death, maybe even higher in some circumstances, right? So it's like, what's the alternative? But this is why we want to titrate slowly and judiciously up. That's the same with other vasopressors, right? So 5 micrograms per kilogram per minute, we go up by 5 micrograms per kilogram per minute to a max of 20. We'll go over the dosages momentarily. And as well, if we achieve that blood pressure, we want to wean it off slowly. So we don't just shut it off unless we have to, if they go into cardiac arrest or something, because if you shut it off too quickly, this can cause rebound hypotension and as well as cause adverse events. Then there is this clinical consideration here. Contact the BHP if the patient's bradycardic. That's just have a good discussion. What's the best treatment plan for this patient? Will it be pacing? Will it be dopamine? Will it be other measures? Will it be a mix of both, right? That's just to get that conversation going, because again, pretty complex patients, and it could warrant, and paramedics can benefit from the extra aid from the base hospital physician. So the good thing about dopamine, it works fairly quickly. So it works within 5 minutes. It only lasts from less than 10 minutes, and its half-life's less than 2 minutes, which can be beneficial, right? So it doesn't last that long. Again, we just want to get the least amount of vasopressor to achieve a blood pressure between 90 and 110, or a MAP of 65, which means you're just perfusing your vital organs. And this brings to this point. What if the patient's experiencing an insult and it's a suspected cardiogenic shock, but the blood pressure is 88 on 60, but their skin is decent, they're not altered, they're GCS 15, they don't have pulmonary congestion, etc., right? It's like, does this patient really warrant dopamine? Even though the directive's less than 90, you can't create a medical directive that covers all circumstances, right? It's like looking at the risk and the benefits. I don't want to increase this patient's myocardial workload if their blood pressure is 2 millimeters off from being considered hypotensive, right? Maybe they just get some fluid. Maybe we can just leave them at that place, right? Because it's evident they're perfusing their vital organs at this time. But if they start to trend lower, or they start demonstrating symptoms of altered mental status, they got crackles, they're mottled, they're cyanotic, right? They're not producing any urine. It's like, okay, we need to give them dopamine to increase their perfusion to mitigate any complications to their organs, their brain, their heart, their kidneys, etc., because we need those to survive. And if we look at the different receptors, and we'll go over more extensively in another video, we have dopamine receptors, right? And these are considered dopaminergic receptors 1 and 2. They're involved in our kidneys. Dopamine binds to adrenergic alpha-1 receptors, are responsible for causing vasoconstriction, so you constrict your blood vessels, squeeze out the blood, and hopefully shunt it to your core to help perfuse your vital organs. And beta-1 receptors, which are found in the heart to increase contractility as well as the heart rate. So that's why dopamine can be beneficial for those bradycardic patients when titrated that specific dose. As well, there's beta-1 receptors in the kidney. So we look at dosages less than 2.5 micrograms per kilogram per minute. This causes vasodilation in our actual renal vessels. It causes it in our coronary arteries or brain, etc., right? As well as in our mesenteric vessels. So obviously those are all very valuable organs, and we want to increase blood flow to them to improve the blood supply to them to mitigate the hypoperfusion. But if we look at dosages between 3 and 5 micrograms per kilogram per minute, that's where you get the beta-1 effects, so the increase in inotropy and chronotropy. Then when at 10 micrograms per kilogram per minute or greater, this is where you start to get the vasoconstriction effect. So again, you kind of vasoconstrict your blood vessels to go shunt blood to your core to perfuse your vital organs with that. But again, this is where you kind of get those proarrhythmic events, and this is again why we want to titrate the least amount of dopamine to achieve a normal amount of blood pressure to perfuse their vital organs. So overall, this video was to review a patient context, apply and weigh the risk of giving fluid, giving dopamine, etc., right? Because overall, this patient had pulmonary congestion or acute cardiogenic pulmonary edema. They would have been contraindicated to giving a fluid bolus. Fluid bolus is the first line treatment for cardiogenic shock to increase the preload to help support their perfusion status. However, if they're contraindicated, we don't want to exacerbate the pulmonary congestions because their heart can no longer take and utilize that fluid. So then we move on to dopamine, and this patient would benefit from dopamine because, again, they're manifesting with pretty persistent hypotension and signs of hypoperfusion, evident from being mottled, altered GCS, no radial pulses. 66% of all cardiogenic shock patients will manifest with pulmonary edema, etc. It's like you're severely ill. You need support to bring up your blood pressure to perfuse your vital organs, right? So we'd start with 5 micrograms per kilogram per minute. We did an IV. We'd slowly titrate up. This patient would benefit starting at 5 micrograms per kilogram per minute because that's when you start to get those beta-1 effects to increase your heart rate, contractility, and hopefully that would increase their blood pressure and help perfuse all their vital organs again. And then if they needed that extra support, we could slowly titrate up. So that's why it's beneficial.